All right, guys, welcome to Pharmacology 1. Today we're going to introduce cholinergic agents. So first we'll talk about the cholinergic neuron. When we say cholinergic, we're talking about a neuron that releases acetylcholine as its neurotransmitter. There are various neurons in both the central nervous system and the peripheral nervous system that utilize acetylcholine as their neurotransmitter. All of the preganglionic synapses of the autonomic nervous system are cholinergic neurons. So this is in both the sympathetic and the parasympathetic nervous system. That's kind of weird because we think of the sympathetic nervous system as being adrenergic, as using epi and norepi. But this is the preganglionic synapse. This is the synapse that's occurring at the autonomic ganglia. So this is when the presynaptic neuron is communicating with the postsynaptic neuron. All of them are going to utilize acetylcholine binding to nicotinic receptors. Also at the adrenal medulla, which is sympathetic, but the adrenal medulla also utilizes acetylcholine binding to a nicotinic receptor. Then the adrenal medulla releases epinephrine and norepinephrine. Also, there are cholinergic synapses throughout the central nervous system, all interneuronal synapses in the CNS. So when we have a neuron communicating with another neuron, releasing acetylcholine. Also, the muscles in the somatic nervous system, you guys should be pretty familiar with the fact that it's acetylcholine that the motor neuron releases onto the skeletal muscle fiber in order to stimulate it. And then also postganglionic synapses in the parasympathetic nervous system. Right? So when we talk about the autonomic nervous system out in the periphery, all synapses at the ganglia, so all presynaptic neurons release acetylcholine, right? So all presynaptic neurons release acetylcholine. They're all cholinergic. And the postsynaptic neurons in the parasympathetic nervous system are cholinergic. Also, the postganglionic innervation of sweat glands in the sympathetic nervous system also utilize acetylcholine. So that's kind of like a weird thing. Typically, the postsynaptic neuron of the sympathetic nervous system utilizes epinephrine and norepinephrine, but sweat glands are weird. Sweat glands, they utilize acetylcholine, even though it's the sympathetic nervous system. So here we see that. This is just showing you the progression of innervation, essentially, like as we move from the central nervous system out to the periphery to get to our effector organs. The somatic nervous system, remember, is how we innervate skeletal muscles. There's no ganglia involved. It's just one neuron that releases acetylcholine onto a nicotinic receptor in the skeletal muscle. So that's a cholinergic neuron. Here we see the autonomic nervous system. The autonomic nervous system, remember, utilizes ganglia. There are autonomic ganglia, little masses of neuron cell bodies that are out in the periphery. So we have a neuron before the ganglion, that's the preganglionic neuron or presynaptic neuron. Then we have one after, that's the postsynaptic neuron or postganglionic neuron. All of these, so this is like the ganglion. This happens in the ganglion. This happens in the ganglion. Actually, this first one's not. That's the adrenal medulla, so that's not a ganglion. But these are the ganglia, right? So all of these utilize acetylcholine onto a nicotinic receptor, right? Also in the adrenal medulla, acetylcholine onto a nicotinic receptor. Then the adrenal medulla releases epi and norepi into the bloodstream. They bind to an adrenergic receptor. We'll talk about that in the next chapter. The sympathetic nervous system, right? We have norepinephrine binding to an adrenergic receptor. Okay, we'll talk about that in the next chapter. For the parasympathetic nervous system, we have acetylcholine binding to a muscarinic receptor, right? So we see cholinergic neurons in multiple places. We see a cholinergic neuron innervating skeletal muscle. We see cholinergic neurons as presynaptic neurons in all of the autonomic nervous system. And we see cholinergic neurons as postsynaptic neurons of the parasympathetic nervous system. All right, so on this slide, you guys can see nerve transmission of a typical cholinergic neuron. So up here, this is the presynaptic neuron, right? That's the neuron that's going to release the acetylcholine. Then you see the synaptic cleft, and over here, that's the postsynaptic neuron. And it has a nice little cholinergic receptor where the acetylcholine is going to bind. That could be a nicotinic receptor or it could be a muscarinic receptor, just depending on where the synapse is. So the first step is to actually produce the acetylcholine. In order to produce the acetylcholine, the presynaptic neuron has a co-transporter. It's an active pump that takes in sodium and choline. This transport of sodium and choline into the neuron is actually the rate limiting step in the synthesis of acetylcholine. So this is the step that takes the longest. Once the choline is in the cell, it's acetylated with acetyl-CoA and it becomes acetylcholine. This transport of choline into the neuron can be inhibited by hemicholine. Hemicholine is a drug. We don't use it therapeutically. It's used typically in like research or for investigative purposes. So it's not something that you would be prescribing clinically, but it is possible to block that transport, which would then decrease the synthesis of acetylcholine and decrease the ability of cholinergic neurons to transmit. Once the acetylcholine is produced, it gets stored in vesicles. The vesicle just protects the acetylcholine, so the acetylcholine can hang out here in the synaptic terminal until we're ready to actually release it. And then we have the release of the acetylcholine into the synaptic cleft. What actually happens there is that an action potential, right, a change in voltage comes down the axon of the neuron, and when the action potential depolarizes the synaptic terminal, that's what this little sign is showing you, like a jump in voltage. When it depolarizes the synaptic terminal, that opens this voltage-gated calcium channel. There's more calcium outside the neuron, so when we open channels, diffusion just moves it down its concentration gradient. So a bunch of calcium enters into this synaptic terminal. It's that calcium that causes the synaptic vesicle to fuse with the membrane and causes this acetylcholine to get dumped into the synaptic cleft. Now, once that acetylcholine is dumped into the synaptic cleft, a couple different things can happen. It can travel across the synaptic cleft and bind to the postsynaptic receptor. It could bind to this presynaptic receptor, which we'll talk about in a minute, or it could just be broken down by an enzyme called acetylcholinesterase. Really quick, before we get to all of the possible targets, the release of the acetylcholine can be either inhibited or accelerated just by different chemical compounds. The botulinum toxin that's produced by the Clostridium botulinum bacterium. This is like when someone has botulism, then they have infection with the bacteria and they have botulinum toxin that builds up. This botulinum toxin is also what we use clinically. It's in Botox. You hear people getting Botox injections, and those Botox injections paralyze the muscles, like in the face, for example. When you inject it directly into the muscles of the face, it paralyzes those muscles. They can no longer contract, which decreases the appearance of wrinkles, right? Because wrinkles appear when you contract your muscles of like facial expression. So Botox paralyzes them. The way that Botox does that, the way that it paralyzes the muscles, is by inhibiting the release of acetylcholine. Acetylcholine, remember, is what stimulates skeletal muscles, right? Remember, we just looked at the innervation of our skeletal muscles, and we said that those were cholinergic neurons that controlled skeletal muscles. So if we block the release of acetylcholine, we block the stimulation of skeletal muscle, we prevent contraction. Spider venom from the black widow spider causes the release of acetylcholine. So it's the opposite. It causes huge release, just dumping of acetylcholine into the synaptic cleft, which then causes excess stimulation of receptors. Then the acetylcholine, we said, binds to its receptors. There are the target receptors that we see on the target cell. Again, those can either be muscarinic receptors or nicotinic receptors. The effect that it has depends on the specific cell. Acetylcholine can also bind to presynaptic receptors. Those are receptors on the nerve terminal of the presynaptic neuron. These receptors are actually like neuromodulators. They inhibit the release of more acetylcholine. The thought process there is that if we have enough acetylcholine hanging out here that it's able to start binding to this presynaptic cell as well, then we don't really need any more at that time. Acetylcholine eventually gets broken down, actually pretty quickly. It gets broken down by the enzyme acetylcholinesterase. ACHE, acetylcholinesterase, that breaks it down into its acetate and choline. The choline gets recycled, right? It comes back up and gets pumped back into the nerve terminal to have the acetate to be acetated, get the acetate added to it again. And the acetate just diffuses away. So that's cholinergic neuron transmission. Now, once acetylcholine is released, we said that it binds to either nicotinic receptors or muscarinic receptors. Muscarinic receptors are called muscarinic because they also bind to the natural alkaloid called muscarine. Sorry, I spelled that wrong. Muscarine is a compound, it's an alkaloid compound that's found in poisonous mushrooms. But muscarinic receptors bind to acetylcholine as well as muscarine. We'll see that nicotinic receptors bind to acetylcholine and nicotine. The muscarinic receptors can bind to nicotine, but they bind to muscarine with a much higher affinity. And then the same goes for the nicotinic receptors. They bind with a much higher affinity to nicotine than they do to muscarine. And then acetylcholine's like just right in the middle. It has a like moderate binding affinity to both muscarinic receptors and nicotinic receptors. So muscarinic receptors are G protein coupled receptors, meaning they have those 7 transmembrane spanning regions that go through the plasma membrane, and the acetylcholine would bind at this extracellular binding region, and then the receptor is linked to some sort of a second messenger system that's actually inside the cell. The muscarinic receptors are located on effector organs of the parasympathetic nervous system. Remember, we said all of the synapses that are in the ganglia, those use nicotinic receptors. So muscarinic receptors are found on the parasympathetic effector organs. So heart, we find them on smooth muscle, like smooth muscle in the bladder, in the ureters, in the GI tract, for example. Also on some exocrine glands as well. And then we also find some muscarinic receptors in the brain. The mechanism of signal transduction with muscarinic receptors depends on the type of muscarinic receptor that we're looking at. We clearly understand M1, M2, and M3 receptors. There are actually 5 subtypes of muscarinic receptor, but we haven't functionally classified M4 and M5 well. So when a drug or when acetylcholine binds to an M1 or M3 receptors, the G protein activates phospholipase C. Okay, this goes on and activates other second messenger systems and can result in changes in ion concentrations, for example, inside the cell. Binding to the M2 receptor that means that the G protein inhibits adenyl cyclase, okay, which then again results in other changes inside the cell. Again, note that the acetylcholine isn't actually entering into the cell. It's binding extracellularly, and that there are second messengers inside the cell that lead to that intracellular response. Drugs that bind to muscarinic receptors preferentially target these receptors. However, when they are given at higher concentrations, they lose that selectivity and they can also bind to nicotinic receptors. So that's important to keep in mind that as drug concentrations increase, you lose that selectivity and then you start to get more of a response across, all across the autonomic nervous system, as opposed to just at these parasympathetic effector organs that you might be targeting. Nicotinic receptors, again, bind to acetylcholine, but they also bind to nicotine, which I think we're probably all familiar with the fact that nicotine is a plant alkaloid that's found in tobacco. Nicotinic receptors are ligand-gated ion channels, so the binding of acetylcholine or nicotine to the receptor opens the ligand-gated ion channel. At low concentrations, nicotine stimulates the receptor, but once it binds to the receptor, it then blocks it. So it initially stimulates it, but then stays on board and blocks the receptor. So we see that as concentrations increase, we get more receptors bound and blocked, and it can actually start to have an inhibitory effect. So initially we can see a stimulatory effect from nicotine, but at higher concentrations, we can actually see an inhibitory effect occur. Nicotinic receptors are all over the place. We find nicotinic receptors in the brain. We also find them in the adrenal medulla. Remember, when we have a sympathetic nervous system response, the adrenal medulla is stimulated by acetylcholine binding to nicotinic receptors, and then the adrenal medulla responds by releasing epinephrine and then some norepinephrine as well. We find nicotinic receptors at autonomic ganglia, right, in both the sympathetic and parasympathetic nervous system. And then we also find nicotinic receptors at the neuromuscular junction, where motor neuron stimulates skeletal muscle fibers. The mechanism of signal transduction at nicotinic receptors, 2 acetylcholine molecules have to bind to induce the conformational change in the receptor or in the channel. Conformational change is just like a change in shape. So you have the ligand-gated ion channel is closed typically. But when 2 acetylcholine molecules bind to it, the whole thing changes shape, and that opens up the ligand-gated ion channel. This opens the pathway for sodium. There's more sodium outside the cell, so when a sodium channel is opened, sodium enters into the cell. Sodium is positively charged. So when positive charges enter into the cell, that depolarizes it. right? That makes it less negative. It brings it closer to a threshold voltage, and it increases the chances that you'll have some sort of stimulatory effect in that cell. There are differences between the receptors that are located in different locations. So we can get different results depending on what location the nicotinic receptor is in. Mecamolamine is a drug that selectively blocks nicotinic receptors at the autonomic ganglia. Atracurium is a drug that selectively blocks nicotinic receptors at the neuromuscular junction, right? So there must, I tell you this to demonstrate the fact that there must be differences in the receptor subtypes in these different areas if we can create a compound that selectively binds to them in one area but doesn't bind to them in another area. There must be some differences between the receptors. Atracurium, this is the compound that, like in South America, the tribes would put on the darts, right? And it paralyzes you when it hits you. So it's a paralytic agent because it blocks nicotinic receptors at the neuromuscular junction. Blocking those receptors means that even if acetylcholine is released, it has no receptor to bind to, and you can't stimulate the skeletal muscles. We use atracurium clinically. We use it in patients who are undergoing surgery. We use it like in patients who are ventilated because it causes paralysis, muscle paralysis. But again, it initially was used in South America in the jungle. So we'll talk about direct cholinergic agonists first. An agonist, remember, is something that binds to the receptor and stimulates it. It acts like the endogenous agonist. Direct, meaning it's actually binding to the same receptor that acetylcholine binds to. So we have multiple direct cholinergic agonists that mimic acetylcholine by binding to cholinergic receptors. The choline esters include acetylcholine itself, as well as carbachol, bethanachol, which we use for the bladder, methacholine, which we use in asthma diagnosis, and cevimeline. The naturally occurring alkaloids, like from plant alkaloids, include nicotine, which we mentioned, and pylocarpine. I'm not really worried that you know these categories or anything. Now, we don't really use acetylcholine pharmaceutically or therapeutically. And the reason for that is that it binds indiscriminately to nicotinic receptors and muscarinic receptors, and it would have systemic side effects all over the body. If we gave acetylcholine systemically, it would decrease heart rate and decrease blood pressure. It would increase secretions, right? Salivary secretions, lacrymal secretions, mucus secretions. We could have bronchoconstriction occur. They would increase GI motility. There are just effects all over the body that it would have, and we don't have the ability to give it systemically and have it target one single area. We can, to try and limit the systemic side effects, we can give acetylcholine locally. For example, during surgery, acetylcholine can be given directly into the anterior chamber of the eye. That allows us to limit systemic effects. But acetylcholine has a very short duration of action. It's very rapidly degraded by acetylcholinesterase, and then you have to administer it again. So we've come up with some other agents, some drugs that are longer lasting, but still produce the effects that we were going for. Agents that lack selectivity are pretty limited in their therapeutic usefulness because, again, they just result in side effects all over the body. On the next few slides, we'll talk about pylocarpine, bethanachol, and carbachol. These other two, we don't have quite as much therapeutic usefulness, but cevimeline does show some specificity. It's used to increase salivary secretions in Sjögren's syndrome. Sjögren's syndrome is an autoimmune disease that's associated with pretty severe dry mouth. So we can give the cevimeline, and that binds to cholinergic receptors in the salivary glands and increases those salivary secretions. It does also increase tear production as well. Methacholine causes bronchoconstriction. There's not really any clinical situation where we would want to therapeutically cause bronchoconstriction. It's just used in diagnosis. So it can be used in the diagnosis of asthma. Administering the methacholine binds to the cholinergic receptors in the bronchi and causes bronchoconstriction. Bethanechol. Bethanechol is a strong agonist for muscarinic receptors. So because these are muscarinic receptors, it's not going to affect the skeletal muscle, and it's not going to affect the ganglia, right? So it's relatively specific for muscarinic receptors, especially those that are in the bladder and the GI tract. So it's an agonist, meaning it's going to stimulate these receptors. So we're going to be stimulating the parasympathetic response in the bladder as well as in the GI tract. So that means that it's going to stimulate GI motility, and it's going to stimulate essentially urination, detrusor contraction, and urethral sphincter relaxation. The detrusor muscle, remember, is the muscle that's in the lining of the bladder. And when we urinate, the detrusor muscle contracts to squeeze the bladder, and the urethral sphincter relaxes. The internal urethral sphincter, which is smooth muscle, relaxes to allow the urine to leave. So bethanechol can be used to stimulate urination. The duration of action is relatively short. It's only active for about an hour. And we use it specifically for this this stimulation of urination. We use it to stimulate an atonic bladder. Atonic is like no tone. So there are some clinical situations where there's just no tone in the bladder and the person can't relieve their bladder. We see this postpartum, so in women who have just given birth, and we also see this in some post-operative states as well. Obviously, you can't use it if there's any obstructive urinary retention going on, only if it's non-obstructive. Also, neurogenic atonia and megacolon. This is because of the GI effects, to the stimulation of GI motility, but most frequently we use this in the bladder. Again, it's relatively short-acting, so you give it, it stimulates the bladder. Once the bladder's been stimulated, it normally then kind of takes over for itself. Adverse effects include just really a generalized cholinergic response. This is a cholinergic agonist, and it's binding to muscarinic receptors, so it's especially has a good affinity for receptors in the bladder and the GI tract, but it can still bind to other muscarinic receptors, so it can still stimulate other cholinergic type symptoms. So adverse effects include sweating, salivation, flushing, decreased blood pressure. The decrease in blood pressure can result in reflex tachycardia. The tachycardia seems kind of weird when you're thinking about a parasympathetic response, right, or cholinergic, because typically cholinergic lowers the heart rate, and it's typically the sympathetic nervous system that increases heart rate. But the body does have reflex systems to make sure we're getting enough blood out to the tissues. So if the blood pressure decreases, the body's reflexes to increase heart rate. So frequently you'll see things that decrease blood pressure end up having a reflex increase in heart rate, which can result in tachycardia. Nausea, diarrhea is also possible. Bronchospasm is possible. Remember, cholinergic neurons are responsible for causing bronchoconstriction. So you use caution in a patient who has asthma. Atropine, which is a cholinergic antagonist, is administered to overcome severe cardiovascular or respiratory effects. So if you, say, have a patient who just had a baby and you removed the epidural and they're not urinating, they have atonic bladder, you administer botanicol, and the patient has, bronchospasms that are occurring. Or you could say, the patient has a really bad decrease in blood pressure. Giving atropine can reverse those effects, can overcome those effects. Atropine, again, is a cholinergic antagonist. So it'll bind to those cholinergic receptors and block them to prevent this effect from botanicol. Pylocarpine is another direct-acting cholinergic agonist. Again, a muscarinic agonist, so it binds to muscarinic receptors and stimulates them like acetylcholine would. We use pylocarpine topically, typically in the eye. When we apply it topically to the eye, it causes miosis, which miosis is a constriction of the pupil, right? So you would see like pinpoint pupils. It also causes ciliary muscle contraction and opening of the trabecular meshwork. This opening of this trabecular meshwork allows for drainage and a decreasing of intraocular pressure. That's important in, for example, emergency like situations where intraocular pressure is really high in glaucoma. And we'll see that just right down here real quick. It's a potent stimulator of secretions, but it does that relatively non-selectively. So it stimulates the secretion of saliva, but it also stimulates the secretion of tears, and it stimulates sweating and GI secretions, and so it stimulates all sorts of secretions. It does penetrate the central nervous system. That is important when we talk about poisoning, for example, the fact that it penetrates the central nervous system, because if we give an antidote, we need to make sure that the antidote is able to cross the central nervous system as well. Otherwise, it's not going to reverse all of the effects of the pylocarpine poisoning. Therapeutic uses, the primary use that we use it for is ophthalmic. I mentioned that we use it for glaucoma. In glaucoma, patients have increased intraocular pressure. We use pylocarpine chronically, but we can also use it in acute situations. DOC is drug of choice. Whenever I tell you that something is the drug of choice, you should know it. Make sure you memorize it. You learn it, you keep it in your mind forever. So pylocarpine is the drug of choice for emergency lowering of intraocular pressure in both open-angle glaucoma and closed-angle glaucoma. Okay, so emergent situations where the patient's eyes are at risk because intraocular pressure is so high, you give pylocarpine drops. It works quick. It works in minutes. A few minutes it works, and then it lasts for like 4 to 8 hours. And then you can repeat it after that if needed. But the fact that it works well and it works so quickly makes it good to use in emergent situations. It also can be used chronically. So there are pylocarpine eye drops that can be used chronically for glaucoma. It does reverse the mydriasis of atropine. So if atropine is given, for example, atropine dilates the pupils. So if atropine dilates the pupils and you need to reverse that, pylocarpine will reverse that mydriasis or that dilation. It can be given orally to increase salivation in dry mouth. Xerostomia is dry mouth. So patients typically have severe dry mouth post-radiation therapy, or again, in the autoimmune condition, Sjogren's syndrome. Sorry, I keep choking over it. Sjogren's syndrome. So when we give it orally, however, it has more of an effect kind of systemically or all over the body, so it's associated with more side effects when it's given orally versus when it's given in an eye drop. Side effects include of the eye drop and oral include blurred vision, night blindness, and brow ache. If it's given orally, though, it has additional side effects, for example, of salivation, sweating, blood pressure effects, etc. Poisoning from pylocarpine presents with an exaggeration of the typical peripheral nervous system effects. So imagine, someone's diaphoresis is sweating. So someone's sweating like crazy, salivating like crazy. Those are signs of pylocarpine overdose. Pylocarpine overdose can be treated with atropine. Okay, so you can think of atropine and pilocarpine as being opposites. Okay, pilocarpine is a cholinergic agonist. It acts like acetylcholine. Atropine does not. Atropine is a cholinergic antagonist. You can think atropine attacks the cholinergic system. Okay, it blocks it. The atropine has to be given, though, at high enough doses to actually be able to enter the central nervous system, and that's important. If you have to give the atropine like parenteral doses, so IV doses that are high enough to cross the blood-brain barrier. Otherwise, you're not going to be able to counteract all of the toxicity of pilocarpine. Adverse effects of cholinergic agonists include SLUD and bloods. SLUD, salivation, lacrimation, urination, defecation. So drooling, tearing up, urinating, defecating. Bloods, bradycardia, right? So decreased heart rate, lacrimation, urination, defecation, salivation. So you can use really either one of these to kind of remember the effects. This is just a comparison of some of the structures of some cholinergic agonists. You can see this is acetylcholine itself, right? Bethanacol, which is just a derivative of acetylcholine. Here you see that it has an amino group here, and then it has an extra methyl group. Carbachol, right, has the amino group. Pilocarpine, you see here, pilocarpine is quite different in structure, but it still does bind to the muscarinic receptors. I'll go ahead and stop here, and we'll talk about the indirect cholinergic agonists in lecture next week.